Bismillahirrahmanirrahim. Today we will have case quiz number 12. Case data: 50 years old male, presented by attacks of painful ears and tenderness across the nasal bridges. Attacks of painful ears with tenderness across the nasal bridge. During each episode, his ear feels swollen, burning, and hot to touch. So there is hotness, swelling, and pain in the ears and nasal bridge, with occasional nasal bleeding. The patient had no past history of medical importance. On examination, the patient has bogey swelling with purplish discoloration, with saddle nose deformity, and the right eye show injected sclera, with polyarthritis of the hands. Investigations showed hemoglobin increased 15.6 but not exceeding the normal values. White BCs within normal. Platelet slightly increased over the upper limit, 500 rather than 450. ESR elevated moderately, 47. Immunoglobulin showed polyclonal hypergamma globulinemia. ALT and AST within normal. Creatinine within normal. Urine analysis normal. Chest X-ray normal. Rheumatoid factor negative. Anti-CCP negative. ANA by ELISA is weakly positive, and anti-double strand is negative, and finally ANCA is borderline. So what is the diagnosis? The answer is yes, you are right. The answer is relapsing polychondritis. The differential diagnosis of a collapsed nasal septum and saddle nose deformity is relapsing polychondritis, Wagner granulomatosis, and congenital syphilis. The auricular disease in this case is limited to the cartilage as the earlobe is spared. This effectively rules out cellulitis, and the most likely cause of such multifocal cartilaginous inflammation is relapsing polychondritis. Relapsing polychondritis is characterized by histologically by inflammatory infiltration and later fibrosis of cartilage. Any cartilage in any location is at risk. But the box shows classic sites for clinically relevant disease. The next box we will show the most commonly affected cartilages. This box shows the clinical features of relapsing polychondritis. First, the auricular disease with attacks of painful inflammation and development of cauliflower ear. Second is nasal chondritis with painful nasal fullness, epistaxis, and nasal septal collapse. Arthritis, generally oligo or polyarticular arthritis, which is non-erosive. Ocular disease, episcleritis, conjunctivitis, and uveitis. Respiratory tract, throat tenderness, hoarseness, stridor, and tracheal stenosis. Audiovestibular conductive hearing loss, tinnitus, and vitiligo, cardiovascular aortic root dilatation, associated conditions, systemic vasculitis, glomerulonephritis, systemic lupus erythematosus, rheumatoid arthritis, and other rheumatological conditions, and myelodysplasia. All of these may complicate or associate with relapsing polychondritis. So the most common tissues affected are ear, nose, joints, eye, respiratory tract, and audiovestibular with cardiovascular systems. Diagnosis of relapsing polychondritis is clinical, as there are no diagnostic tests. The results of investigation in this case are typical. The ESR can be used as a predictor of disease activity in some patients. Treatment of relapsing polychondritis is with corticosteroid, the dose of which is within 20 to 60 mg per day depends on the severity of organ involvement and the risk of major structures. The majority of patients will need a protracted course of steroid, so steroid-sparing agents should be considered at an early stage, and bone protection is mandatory in order to prevent or decrease the osteoporosis complications of steroid. Surgical reconstruction of collapsed structures is not an option, as the deformity tends to continue post-operatively. Take a home message. Relapsing polychondritis is a cause of painful ears, but the loop is characteristically spared, differentiating it from cellulitis, and any cartilage may be affected. And finally, thank you very much for your attendance, and we will meet you in the next future with case quiz number 13. Wassalamu alaikum wa rahmatullahi wa barakatuh.